Multiple myeloma is a very rapidly changing field. We have so many drugs. I mentioned earlier, I was at the FDA on April 12 presenting for the ODAC. I met with the head of FDA's oncology program, and he told me, talking to him one-on-one, that myeloma has been the number one disease for drug development, and with the win for MRD as an early endpoint for accelerated approval, he said, you guys did it again. So myeloma has really been pioneering the field, and having MRD as an early endpoint will allow us to develop drugs for newly diagnosed patients. Instead of waiting 12 years, it could be done technically in, say, in 3 years. So we will probably see more and more new drugs coming. So you could joke and say that the good news is that we have come a long way. The bad news is it's going to go even faster. So people really need to stay on top of the game. I think the complexity of many of the newer drugs is very different compared to the older drugs. You could give Velcade, or you could give Melphalan or Cytoxan. They are sort of easy drugs to give. They have their side effect profiles. But with the newer antibodies and other immunotherapy approaches, you need to know what to look for. You need to avoid, you don't run into cytokine release syndromes. You don't run into immunosuppression that could lead to very severe infections. So they're very, very effective drugs. They're very powerful. But if patients start developing signs of certain side effects, as a doctor, you need to know what to look for. You need to know how to manage it, so you don't cause new problems for the patient. You have removed the myeloma problem, but you don't want to introduce a new one. I think there is also work that needs to be done by people like me and others to develop the ultimate dosing schedule that would include both the dose and the interval. I think that the safety can probably be optimized and without jeopardizing the efficacy. I think we have already seen that the antibodies initially were approved for once a week, and quickly people started doing in trials every other week. And that was updated in the approvals for the labels for the FDA. And you can also use them once a month even. So I'm not saying to people who listen here, go home and try whatever you think is the best. So this needs to be done in a structured, in an organized way. But I think the field seems to be going towards less frequent dosing intervals. And the doses can probably also be cut back on some of them. In particular, I think GPRC5D to mitigate a lot of the side effects. So there's work that needs to be done on the translational, on the clinical side. It's sort of ironic. First the drugs get approved and then we figure out how to use them. But this is how the field has been, in my experience, for at least the past 20 years.